In this systematic review and meta-analysis by Drs. Hamdy, Jones, Ziegler, Basu, and Oyer, the authors evaluated functional outcomes following hypoglossal to facial nerve transfer for acute facial paralysis. This procedure was originally described in the early 1900s and was predominantly used for facial reanimation for patients with acute facial paralysis, typically following CP angle tumor resection. The original description involved cutting the entire width of the hypoglossal nerve and connecting this in an end-to-end fashion with the main trunk of the facial nerve. This produced significant improvement in facial tone as well as voluntary facial movement triggered by tongue movement. However, since the entire hypoglossal nerve was cut, there was a predictable amount of tongue atrophy and resulting speech and swallowing dysfunction that compounded the cranial neuropathy the patient already experienced from their facial nerve weakness. Future refinements of this technique have used only a portion of the hypoglossal nerve, typically up to 40%, and connected the main trunk of the facial nerve to the partial hypoglossal nerve in what was described as a geometric end-to-side fashion. Additional modifications have used an interposition graft to connect the side of the hypoglossal nerve with the side of the facial nerve in what was termed a side-to-side or split nerve transposition. In this systematic review, the authors sought to evaluate whether the facial nerve outcomes decreased as less and less of the hypoglossal nerve was used, and also to look at the tongue atrophy and synkinesis outcomes, as well as speech and swallowing dysfunction when just a portion of the hypoglossal nerve was sacrificed. This systematic review was carried out according to PRISMA guidelines, with a thorough search of the literature evaluating hypoglossal to facial nerve transfer in any one of the three configurations described, and when authors evaluated a validated facial nerve outcome. In this case, all studies ended up evaluating the House-Brackman scale rather than some of the more modern facial nerve outcome scales such as FACE or E-FACE. The authors of the study specifically excluded studies that evaluated multiple nerve transpositions or free muscle transfer to try to achieve the most homogeneous study population available. Ultimately, 49 studies, including 961 patients, were included in this meta-analysis. Most of these represented retrospective studies and case series describing patients treated with various types of hypoglossal to facial nerve transfers. The main outcome measure evaluated was the House-Brackman outcome reported by the authors, and this was categorized into a good House-Brackman outcome if this fell in the House-Brackman 1 to 3 range. Secondary outcomes included rates of synkinesis, as well as tongue atrophy and speech or swallowing dysfunction. When looking at the primary outcome, the end-to-end traditional hypoglossal to facial nerve transfer produced 57% rate of a good House-Brackman outcome. This was compared to 76% good House-Brackman outcome in the end-to-side group and 50% in the split anastomosis. These numbers were not statistically significant on analysis. Similarly, the synkinesis rates between the three types of anastomosis were statistically similar. In the end-to-end group, 60% of patients developed synkinesis, compared to 69% in the end-to-side group and 36% in the split anastomosis. There was a significant decrease in tongue atrophy as expected in the hypoglossal to facial nerve anastomosis that did not section the entire hypoglossal. In the end-to-end group, 77% of patients developed tongue atrophy. This dropped to only 19% in the end-to-side group and 0% reported in the split anastomosis group. Both of these were statistically lower than that in the end-to-end group. Similarly, there was less speech and swallowing dysfunction, with a rate of 36% in the end-to-end group compared to only 4% in the end-to-side or 0% in the split hypoglossal group. In a subgroup analysis of the end-to-side anastomoses where an interposition graft was used compared to those where the main trunk of the facial nerve was hooked directly to the hypoglossal, the authors did find a difference in the proportion of patients with a good House-Brackman outcome. Among those where a graft was used, 59% of patients achieved a good House-Brackman outcome. This improved to 79% when no interposition graft was used. This supports the theory that the fewest number of neural anastomoses should be used to optimize facial nerve outcomes. However, it's also important to minimize any tension on a neural repair. This study had several limitations which are common to all systematic reviews. That is, that the individual studies had varying methodologies, surgical techniques, as well as outcomes and follow-up time. All the studies included used the more traditional House-Brackman scale rather than the more contemporary Sunnybrook or E-phase scales, which could produce more granular data and define more finite differences between these neural anastomoses types. Despite these limitations, the conclusions of this study indicate that there's no decrease in facial nerve power produced when using only a portion of the hypoglossal nerve during a hypoglossal to facial nerve transfer. So surgeons can have some confidence that they're producing the similar amount of facial nerve function while reducing the amounts of tongue atrophy as well as speech and swallowing dysfunction. The study also demonstrated that an end-to-side anastomosis with an interposition graft tended to produce less robust facial nerve outcomes compared to those without a graft in place. As always, further study is beneficial in this area to help further define the criteria for various nerve anastomosis geometries and improve our ability to make better decisions for patients in these circumstances.